Good day to everyone. Today, I would like to give a talk about tuberculosis in primary care. I hope this talk will benefit all of you in your daily practice. The outline of today's presentation include the introduction of pulmonary TB, epidemiology, who do we screen for TB, smear-positive tuberculosis, smear-negative tuberculosis, extrapulmonary tuberculosis, tuberculosis in special situation, HIV with TB, TB in children, BCG lymphadenitis, congenital and neonatal tuberculosis, patient-centered care, and anti-tuberculosis adverse drug reactions. Introduction. Tuberculosis is endemic in Malaysia. Pulmonary tuberculosis is the most commonest form of tuberculosis in Malaysia. Pulmonary tuberculosis is an airborne infectious disease. Tuberculosis is caused by a bacteria called Mycobacterium tuberculosis that often affects the lungs. What most people don't know is tuberculosis is curable and preventable. TB is spread from one person to another through the air. When people with lung TB cough, sneeze, or spit, they propel the TB germs into the air via air droplets. When a person breathes in the TB bacteria, the bacteria can settle in the lungs and begin to grow. From there, they can move through the blood to other parts of the body, such as the kidney, spine, brain, and GI tract. The vision of the National Strategic Plan for TB control is for Malaysia to be free of tuberculosis by the year 2035. The challenges for TB management in Malaysia include the delay in TB diagnosis and treatment, especially in the smear-negative TB, extrapulmonary TB, and high default rates in TB in children. Hence, it is very important for doctors to know when to refer and who to refer when in doubt. Epidemiology. The number of tuberculosis cases in Malaysia continue to rise, leading to high rates of mortality and morbidity. There were 1,700 TB deaths in 2015, and these has increased to 2,320 deaths in the year 2020. As you can see from this slide, the number of TB cases are increasing in Selangor from the year 2015 till the year 2019. This slide shows us the TB cases according to the districts in Selangor from the year 2017 until the year 2019. This is the TB cases in Selangor according to the age group. This slide shows us the TB cases in Selangor according to the gender, men and women from the year 2017 till 2019. The TB cases in children are also on the rise, as you can see from the trend from 2017 till 2019. Who do we screen for tuberculosis? Important high-risk groups include A. Close contact TB, B. Immunocompromised patients such as diabetic mellitus patients, HIV patients, patients with chronic obstructive pulmonary diseases, end-stage renal disease, malignancy, malnutrition, and the use of immunosuppressant drugs. The third group of people that we screen are substance abusers, such as drug users, intravenous drug users, excessive alcohol consumption, and current cigarette smokers. The fourth group is the people living in overcrowded conditions, such as the homeless, and those living in the prisons, and those living in institutions. Clinical features of smear-positive TB include chest symptoms such as productive cough, hemoptysis, and chest pain. Constitutional symptoms such as loss of appetite, unexplained weight loss, fever, night sweats, and fatigue. We must remember typical symptoms may be absent in the immunocompromised or elderly patients. Investigations for pulmonary TB. All patients suspected of having pulmonary TB should submit at least 2 sputum specimens for microscopic examination. When possible, at least 1 early morning specimen should be obtained, as sputum collected at this time has the highest yield. Microbacterial culture must be sent before the starting of TB treatment. Chest radiography. Chest radiography should be used as the primary imaging modality to aid the diagnosis and management of pulmonary TB. Radiographic abnormalities are often seen in the apical and posterior segments of the upper lobe or in the superior segments of the lower lobe. However, lesions may appear anywhere in the lung and may differ in size, shape, density, and cavitation, especially in the immunosuppressed patients. Other investigations include molecular methods. Nucleic acid amplification tests, NAT, provide rapid results within 24 hours. LPA, line probe assay, is used to detect rifampicin resistance alone or with isoniazid resistance. Expert EPTB or RIF is used to detect TB and genetic mutation associated with rifampicin resistance. Lateral flow lipoarabinomannan assay is a new method for the diagnosis of TB. It detects the lipoarabinomannan, a component of the microbacterial cell wall, within an hour. Upon reviewing a patient with suspected TB, a full history and a clinical examination is a must, followed by performing a chest X-ray and sputum smear microscopy. All patients with clinically diagnosed and/or bacteriologically confirmed tuberculosis must be notified under the Prevention and Control of Infectious Disease Act 1988 to the District Health Office. TB notification is mandatory within 7 days of diagnosis, and failure to notify is compoundable. The treatment of pulmonary tuberculosis. The current standard anti-TB regime consists of a 2-month intensive phase with isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by a 4-month continuation phase with isoniazid and rifampicin. Patients with sputum-positive TB should receive anti-TB drugs for a minimal duration of 6 months. Only daily anti-tuberculosis regime should be used throughout the treatment of pulmonary tuberculosis. Fixed-dose combination of anti-TB treatment. Fixed-dose combination, FDC, tablets is a combination of 2 or more anti-TB drugs. The aim of the FDC tablet is to simplify TB treatment, to prevent monotherapy, and to improve patient compliance as well as to prevent development of drug-resistant TB. This is the recommended daily dosing for FDC in adults according to their body weight. Follow-up and monitoring of pulmonary TB. All patients with anti-TB treatment must be monitored. Assessment of the clinical improvement, adherence to treatment, monitoring medication side effect, and adverse drug reaction to the treatment must be done in every visit. This table shows the investigation that needs to be done before starting TB treatment. During the diagnosis of pulmonary TB, routine blood such as FBC, random blood sugar, RP, LFT, and HIV screening should be done. Sputum AFB direct smear, sputum MTB culture and sensitivity, and chest X-ray should also be done. After 2 to 4 weeks starting medication, we should repeat a sputum AFB direct smear and an LFT. Before the conversion into the maintenance phase, we should always review the sputum AFB direct smear, trace the sputum MTB culture and sensitivity, and do a chest X-ray. At the 5th month, we should do a sputum AFB direct smear, and at the 6th month, sputum AFB direct smear, a chest X-ray, and trace the sputum MTB culture and sensitivity. Patients who have completed TB treatment should be asked to watch out for recurrence of TB symptoms and, if present, to contact their nearest healthcare providers. Patients who develop complications of pulmonary TB, for example bronchial stenosis or hemoptysis, need to be referred to a resp physician. Patients with persistent smear positive should be also referred to the specialist for further management. What do we do when there is an interruption of TB treatment? The treating doctor needs to ascertain the reason and duration of the interruption and then decide whether to restart the entire course or to continue from the last dose or to stop the treatment. Interruption of the intensive phase. If the interruption was more than 14 days, then we need to restart from the beginning. If the interruption was less than 14 days, then we can continue from the last dose. In either situation, the total number of planned doses for the intensive phase should be given to the patient. Interruption in the maintenance phase. If interruption occurs after the patient receives 80% of the total planned doses, the treatment may be stopped if the sputum AFB smear was negative at the initial presentation. If the sputum AFB smear was positive, the treatment should be continued to achieve the total number of planned maintenance doses. If the patient receives less than 80% of the total planned doses and interruption lapse is 2 or more months, restart treatment from the intensive phase. If the patient receives less than 80% of the total planned doses and interruption lapse is less than 2 months, continue treatment from date it stops to complete the full course. Why is my patient's sputum AFB still smear positive? First, we need to know whether the patient has any medical condition. Does he have diabetes mellitus? Is he immunocompromised? Ask regarding the symptoms. Has it improved? Next, inquire regarding the compliance. Is the patient doing DOTS? Next, assess the patient's risk to get multiple drug-resistant TB. Are the anti-TB medication drugs dosage correct according to the patient's weight? Trace the sputum MTB CNS. When possible, assess the serial chest X-ray to look for any improvement. Repeat sputum MTB CNS and other investigations such as LPA when required. Lastly, refer to a chest physician when necessary. This is the algorithm of the management of active TB. Patients with symptoms of active TB and with positive investigation can be diagnosed as pulmonary TB. Hence, we will use the standard regime of pulmonary TB medications, which is 2 months treatment of EHRZ, followed by 4 months treatment of HR. We need to monitor the response of the treatment. Good treatment response, we are able to continue the treatment and complete the treatment. If the treatment response is poor or complication arises, hence we need to refer these cases to the specialist. Smear-negative pulmonary tuberculosis. Clinical symptoms of smear-negative pulmonary tuberculosis is similar with smear-positive pulmonary tuberculosis. However, smear-negative results at initial presentation may delay the pulmonary TB diagnosis. Therefore, a systematic diagnostic approach needs to be considered in smear-negative cases with high suspicion of pulmonary TB. Investigations for smear-negative pulmonary TB include a chest radiography, expert MTB or RIF, and expert ultra. A chest X-ray is helpful in the diagnosis of smear-negative pulmonary TB. Expert MTB or RIF and expert ultra are nucleic acid amplification tests for the detection of TB and RIF resistance. Sputum should be sent for expert ultra if smear-negative pulmonary TB is suspected. This is the algorithm of rapid diagnosis of smear-negative pulmonary TB. Features will be suggestive of active pulmonary TB with the clinical symptoms and chest X-ray. However, sputum AFB direct smear ×3 is negative. Hence, we will proceed for a sputum expert ultra. If the sputum expert ultra is detected, we need to see whether it is RIF resistance. That means whether it is rifampicin resistance. If it is not, we are able to treat this patient like a pulmonary TB patient. If we develop RIF resistance or rifampicin resistance or sputum expert ultra is not detected, we may refer this case to the tertiary center for further management. The treatment and monitoring for smear-negative pulmonary TB are the same as that for smear-positive pulmonary TB. Next, we move on to extrapulmonary TB. Extrapulmonary TB often presents as a diagnostic and therapeutic challenge due to the difficulties associated with assessing the site of involvement and assessment of the therapeutic response. The investigations that we use to aid the diagnosis include expert MTB or RIF and expert ultra. The duration and treatment for extrapulmonary TB differs. If it's tuberculosis of the bone or joint, the treatment can be for 6 to 9 months. If it's tuberculosis meningitis, treatment can be up to a year. And it is 6 months treatment for other forms of extrapulmonary TB. However, the treatment duration may be prolonged depending on the clinical response. Adjunctive corticosteroids regimen. Adjuvant corticosteroids treatment is recommended for TB meningitis and TB pericarditis. Disseminated tuberculosis. Disseminated tuberculosis is the term used to describe TB involving two or more organs from the hematogenous or lymphatic spread. Recurrent tuberculosis. TB reoccurs in a number of patients despite completion of treatment because of reactivation of TB, endogenous reactivation, or a new episode of infection, exogenous reinfection. Microbiological tests should be done to confirm the recurrent TB and to rule out drug resistance. Expert ultra is recommended by WHO for both. Sputums should be sent for both expert ultra and microbacterial culture for individuals suspected to have recurrent pulmonary TB. The treatment regime for recurrent TB is determined by the presence of drug resistance. Hence, rapid drug molecular tests and microbacterial culture should be sent before initiating treatment. Tuberculosis in special situations. Tuberculosis in pregnancy and lactation. For pregnant and lactating women, the standard anti-TB regimen of 2-EHRZ and 4-HR can safely be administered as soon as pulmonary TB is diagnosed. Pyridoxine 30 mg per day is recommended for all women taking isoniazid who are either pregnant or breastfeeding. Breastfeeding should be continued in lactating mothers. The use of oral contraceptive pills during the treatment of TB. Rifampicin drugs such as rifampicin and rifabutin reduces the contraceptive efficacy of both combined oral contraceptive and progesterone-only pills. Hence, an alternative contraceptive method should be used during this therapy. TB with renal impairment. The recommended initial TB treatment regime for patients with renal failure or severe renal insufficiency is 2-EHRZ and 4 months of HR. Pyrazinamide and ethambutol should be given 3 times a week in patients with creatinine clearance less than 30 mL per minute or those receiving hemodialysis. There is a significant renal excretion of ethambutol and metabolites of pyrazinamide, and therefore doses should be adjusted accordingly. Tuberculosis with liver impairment. The management of TB in patients with chronic liver disease is challenging because of the risk of decompensated liver failure. These patients should be referred for special care in a tertiary center. HIV and TB co-infection. TB is one of the most important opportunistic infection and causes of death among people living with HIV. Antiviral treatment during TB treatment is significantly protective against mortality and results in earlier conversion of sputum and cultures. In TB with HIV co-infected patients, antiretroviral treatment should be initiated regardless of the CD4 count. In HIV tuberculosis co-infection, antiretroviral therapy should be initiated within 8 weeks of anti-TB treatment. In HIV-TB patient with a known CD4 of less than 50, ART should be initiated within the first 2 weeks of anti-TB treatment. In HIV with TB meningitis, initiation of ART may need to be delayed until 2 months post-TB treatment. Tuberculosis in children. The diagnosis of TB in children is challenging due to the paucibacillary disseminated disease with a wide range of clinical presentation mimicking common childhood illness. A positive TB contact history, usually an adult, would be a strong indicator of TB in a symptomatic child. Other risk factors include household contact, age less than 5 years old, malnutrition, HIV infection. Clinical symptoms of TB in children include cough, fever, night sweats, hemoptysis, weight loss, chest pain, shortness of breath or fatigue. In children less than 5 years old, we should also look for anorexia, failure to thrive, a child that does not eat well, or has decreased activity or playfulness. In children less than 10 years old living with HIV, any current cough, fever, history of contact with TB, or reported weight loss or confirmed weight loss more than 5% since the last visit or growth curve are suspected to have pulmonary TB. With children more than 10 years old with HIV, any current cough, fever, weight loss, or night sweats, then you're suspecting tuberculosis in these children. The treatment of TB in children is similar to adults. Anti-TB dose in children must be calculated according to their weight, and the total dose must not exceed the maximum dose allowed. This table here shows the drugs that we use for anti-TB drugs. This table shows the fixed dose combination of anti-tuberculosis regime in children according to their weight. BCG lymphadenitis. BCG is given at birth and is effective in preventing disseminated TB, including TB meningitis in childhood. BCG lymphadenitis usually occurs 2 to 4 months after BCG vaccination. The most common lymph nodes are the ipsilateral axillary lymph nodes, followed by the supraclavicular or cervical region. Most non-suppurative BCG lymph nodes will regress without intervention in 4 to 6 months and can be managed conservatively. Children with large suppurative BCG lymphadenitis and with constitutional symptoms, generalized lymphadenopathy, and hepatosplenomegaly should be referred to the pediatrician for further management. Congenital tuberculosis. Congenital tuberculosis is caused by the transplacental spread of TB through the umbilical vessels, aspirated or ingested infected amniotic or cervical vaginal fluid in utero or intrapartum. Symptoms onset are usually within 3 weeks. Pulmonary, abdominal, and disseminated TB are the usual manifestations. Neonatal tuberculosis. Neonatal tuberculosis is TB acquired postnatally when newborn is exposed to an infectious adult. Usually it's the mother, but sometimes it can be other household members. Identifying an infectious adult will be the key indicator of neonatal TB. Investigations for both congenital and neonatal TB are similar as in older children and adults. All newborns to mothers with active TB need to be screened for TB. Mothers whose current sputum smear is positive or those receiving less than 2 months of TB treatment are still considered infectious. This slide shows the algorithm of management of newborn to mother with active TB. If newborns have features suggestive of congenital TB, this newborn should be referred immediately to the pediatrician. If the newborn has no features suggestive of congenital or active TB, and the mother was diagnosed and treated for more than 2 months before delivery, the newborn will be given BCG at birth and followed up for 2 years to look for active TB signs and symptoms. If the newborn has no features suggestive of congenital or active TB, but the mother was not treated for TB, hence we need to defer the BCG at birth for this type of cases, start isoniazid treatment for 6 months, then only give the BCG at the end of the treatment of isoniazid. This newborn is to be followed up for 2 years looking out for active TB signs and symptoms. Patient-centered care. Patient-centered care is one of the main pillars of the WHO end-TB strategy of ending TB by the year 2035. In Malaysia, directly observed treatment or DOT is supervised by healthcare providers, family members, or community volunteers. Directly observed treatment should be tailored to patients' preference and their risk of default. Video observed treatment, VOT, is recommended by WHO as a new form of DOT. Directly observed treatment should be done in the intensive phase of TB treatment. Video observed treatment should be an alternative to directly observed treatment in selected patients where facilities are available. Self-administered treatment may be offered to patients who cannot perform video observed treatment or directly observed treatment. Anti-tuberculosis adverse drug reaction. An adverse drug reaction is an expression that describes harm associated with the use of the given medication at a normal dosage during normal use. The adverse drug reaction of anti-TB drugs can be classified into 2 categories. Adverse drug reaction which are troublesome but not serious, such as nausea, tiredness, pruritus, and minor rashes. These can be treated symptomatically without having to interrupt treatment. Most of this will resolve spontaneously even when the treatment is continued. Adverse drug reaction which need immediate discontinuation of treatment, such as severe skin reactions, such as Stevens-Johnson syndrome, toxic epidermal necrosis, and drug rash with eosinophilia and systemic symptoms, stress, and hepatitis. The system that is most affected with the anti-TB medication is the hepatobiliary system, followed by the gastrointestinal tract, skeletal system, skin, and renal. Among the anti-TB medications, pyrazinamide is the most commonest drug associated with adverse drug reaction. The incidence of pyrazinamide-induced hepatotoxicity and rash was substantially higher than other first-line anti-TB medication. This table shows us the adverse drug reaction, drug-drug interaction between TB medications: isoniazid, rifampicin, ethambutol, streptomycin, and pyrazinamide. Isoniazid can cause burning and numbness or tingling sensation on the hands and feet. Rifampicin causes orange or red urine. Ethambutol can cause visual impairment, while streptomycin causes deafness and decreased urine output. Pyrazinamide can cause hepatitis. This picture shows us an example of the drug-induced rash. It could be sometimes mild and self-limiting, or it could be severe adverse drug reaction like SJS, TENS, and DRESS. Drug-induced hepatitis. Drug-induced hepatitis is usually caused by pyrazinamide, isoniazid, and rifampicin. Pyrazinamide being the most hepatotoxic and rifampicin the least. It usually occurs within the initial 2 months of treatment. Monitoring should be for the first 2 to 4 weeks. Stop the treatment if ALT is or more than 3 times of the upper limit of normal in a symptomatic patient. Stop the treatment if ALT is or more than 5 times of upper limit of normal in an asymptomatic patient. This is my references. Hope this PowerPoint presentation has benefited you. Thank you.